part of the problem is being human. And, you don't get crocodiles or apes or having OCD, but only humans have this sense of self and that ability to imagine things in the future in ways that could be dangerous in some way, and to therefore activate your old brain and to go round in these tricky loops.
You are listening to a Maudsley Learning Podcast.
David Veale is a British psychiatrist. He is a visiting professor in cognitive behavioural psychotherapies at the Institute of Psychiatry, Psychology and Neuroscience, King's College London, and a consultant psychiatrist at the South London and Maudsley NHS Foundation Trust. His main clinical expertise is in the treatment of OCD, BDD, body dysmorphic disorder, emetophobia and depression, and he's developed and evaluated protocols for BDD and emetophobia that are used by other cognitive behavior therapists. He's the author of 3 books, including Free Yourself from Emetophobia, Body Dysmorphic Disorder, A Treatment Manual, and Overcoming OCD. Professor Veale, thank you very much for joining me on the podcast today.
Thank you.
Something I'm always interested in is how people end up in the particular specialism that they end up in. And obviously you're known for obsessive compulsive disorder, body dysmorphic disorder, conditions along those lines. What do you think, if anything, drew you to dealing with that particular set of conditions?
Well, I think my inspiration was when I was a specialist trainee under Professor Isaac Marks here at the Institute of Psychiatry. And he, I think, taught me the enormous difficulties sometimes in helping people with OCD, and the enormous sort of heterogeneity of the condition, in the sense that everyone that you meet has something different about them, so that there's always something new to learn from every person that you meet with OCD. And yet it is a treatable condition, and can be enormously satisfying to help people change.
Mm-hmm. And OCD really is a phrase that's entered the popular culture now, and people use it quite informally, as they do, depression, trauma, anxiety. But how would you explain what obsessive compulsive disorder is to a layperson?
Yeah. So, I think what you're referring to there was that often you hear in the popular culture sometimes, I'm a little bit OCD, and it's very annoying to people with OCD because it's a serious condition. And so OCD stands for Obsessive Compulsive Disorder, and therefore it consists of both obsessions and usually compulsions. And of course it's a disorder, and therefore by disorder it means it's sufficiently time-consuming, distressing, or interfering with your life in some way. And the nature of obsessions are that they're distressing, intrusive thoughts, images, sensations, urges that just will pop into your head, and they're frequently unwanted, distressing, and usually against your values, and they're difficult to control or get rid of. And so an example might be perhaps the sensation of your hands being contaminated with bodily fluids, perhaps, or a doubt about whether you just run over a cyclist, or an image of stabbing your baby, or a strong urge to have objects placed in a particular order so they feel right. There are many different types of obsessions. They're usually about trying to prevent something bad from happening, some harm, or just to avoid a feeling of disgust, or just to avoid feeling not right in some way. And so the other side of the coin to the obsessions is the compulsions. And these are things you have to do repeatedly. So it can either be observed by others, for example, checking something like a door is locked, or it could be a mental compulsion that you can't be observed, like saying a certain phrase until it feels right in some way. And both of those things are like two sides of a coin, and they're usually associated with various avoidance behaviors as well. So in order to avoid an obsession being triggered, let's say if you've got fears of contamination, you might be avoiding touching certain handles or toilet seats and things like this that you think are going to trigger off your fears of contamination. So it's obsessions, compulsions, and avoidance behavior, plus main emotions are anxiety and sometimes disgust.
Mm-hmm. So it becomes like a cycle, doesn't it, where you have obsessions, these intrusive thoughts and images, and they seem to come, like all thoughts, kind of spontaneously out of the ether without the person actively thinking about them. They come in, they're usually quite distressing, they generate a lot of anxiety, and then the compulsions, there's some connection in that the compulsions are thought to be a way to ameliorate the anxiety generated by those obsessions.
And I would say there are four main themes.
Mm-hmm.
The first is the theme of contamination, where it's triggered by germs, viruses, or just sort of poisons in some way. And there is this big issue about trying not to transfer one piece of contamination to another. Yeah. And the second main type of OCD is to do with responsibility for harm. So that could be a burglary or a fire or running over a pedestrian or something like that. The third main type of OCD is unacceptable thoughts, particularly to do with sex and violence and religion and blasphemy or relationships in general. And the fourth main type of OCD is to do with an urge for order and completeness and symmetry. So, and very often people have, not just one type of OCD, but they've got other sort of dimensions as well. So they've got sort of OCD galore, or 2 or 3 different types of problems, but usually one is dominant.
Is there an age where people tend to very typically develop OCD?
Yeah, I mean, it typically presents during adolescence or being as a young person in the 20s. But it may take up to 10 years before the person is actually getting the right help. So it does. It's often for many people it is a chronic problem. It can occur in children and it can occur in the elderly, but it's commonly a sort of young person that develops it first.
Do people find it hard to recognize that they have a mental health condition? Because it seems like a lot of I suppose to some degree it depends on the bizarreness of the obsessions. That kind of obsessions I've met clients with very bizarre obsessions that at face value you realize that something's wrong, but more typical ones like the need for order and symmetry or the fear of contamination, those can be at face value seem a bit more ordinary. In those kinds of client groups, can it take them a while to work out that something's not quite right here?
Well, I think we all recognize that we have a tricky brain. One part of the brain knows that some of these ideas and problems are absurd and ridiculous, but of course another part of the brain, the old brain, is very fearful and trying to keep us safe. And we can have those two parts of the brain working, with one another. But usually when the fear systems and structures of the old brain are activated, it usually dominates, so that's what takes over. And however much illogical and ridiculous you think it is, it's the fear system that drives your behavior.
Is it well understood what's happening at a neurological level in someone with OCD?
Not really. I mean, I think people can paint a broad brush in terms of what seems to be happening in certain circuits in the brain between the old brain and the basal ganglia and so on, and the new brain up in the orbital frontal circuits. But, it's still very limited in terms of what that means. and it's not very specific yet.
Like you said, it seems to, from a phenomenological point of view, we have one aspect that's the fear, that's very, what you referred to as old brain. And the other aspect that seems quite new, thoughts like higher level cognitive functioning. And there's this sort of strange relationship between the two, which is interesting in a sense. Is there known to be a kind of a genetic basis for OCD?
Sure. I mean, like most emotional disorders, at least probably 40% is heritable. But as I said, part of the problem is being human, and You don't get crocodiles or apes or having OCD, but only humans have this sense of self and that ability to imagine things in the future in ways that could be dangerous in some way, and to therefore activate your old brain and to go round in these tricky loops between the two. So, and obviously there are things which shape you as well during childhood and adolescence, which are going to be important. And sometimes it can be, quite obvious trauma memories in some way. Sometimes linked to not necessarily trauma, but aversive experiences of being teased or bullied or betrayed in some way. So, as in most mental disorders, there is a jigsaw, and we know some piece of those jigsaws and the heritability and things that shape you, but obviously there are many things that we don't know. We don't really fully understand yet, obviously, how it all fits together.
Mm-hmm. Yeah, I think it's interesting that you mentioned trauma. A lot of mental health conditions are now being viewed through the window of trauma. And the way I've started to think about it is that you have a certain genetic makeup that might predispose you to one condition or another. Like you might have a genetic makeup that might predispose you to psychosis, schizophrenia, or bipolar, or depression, or OCD. And then the trauma may serve as an environmental activator. I had a client once who had a very big specific trauma related to their capacity to injure other people. So he had a trauma related to that. And then he developed very severe OCD later on. And all of his obsessions had the theme that he could be of harm to someone. And have you noticed the link between the theme of the trauma, if the person has trauma, and the theme of their obsessions?
Yes, very much so. I mean, I think one of the things that concerns some psychiatrists is the word trauma, because of course it's not to really be confined to those things that might be linked to post-traumatic stress disorder, or things which are a major threat to your sense of self. But that's not to also minimize the very difficult experiences that many people have from, as I said, it's bullying or being humiliated or whatever it is. So there are clearly many aversive experiences that are contributing to these sorts of memories. And we've got some data on being able to help people emotionally process those sorts of traumatic memories. Using things like imagery rescripting, which is an intervention that's used in CBT for treating PTSD to help people to emotionally process those events. And that can also be particularly helpful in a whole range of emotional disorders now, but particularly things like OCD, social phobia, and things like that, where you actually go back to those early experiences and try to help people to develop a different association with that memory, where they're usually in control in some way and getting back at the person who provided that particular trauma and so on. So I think there is definitely, for some people, maybe about 20-25%, often clear associations with old aversive memories and traumas.
It's so interesting, isn't it? Because control is, of course, another theme in OCD, and it's something that people in general seem to have this. I think some people lean towards over-controlling, and those people need to learn how to control their circumstances less. Some people seem to veer the other direction. They're more go with the flow, happy-go-lucky, and people who are more into controlling get mad at them. Yeah. And they need to learn how to control more. So this is a very delicate balance we're all trying to achieve between too much and too little control. And it seems with OCD, they lean in the direction of too much control.
Yes, and I would say it's also to do with the control that one is trying to do in one's inner world. So if you're trying to control or influence, the experience of intrusive thoughts and images or emotions and so on, and particularly if you really find it difficult to tolerate uncertainty and not knowing something, then it tends to lead you to want to try and control or suppress and avoid your inner experiences.
Yeah, I find, because I what I like about learning about mental health conditions is they're kind of an exaggeration of a feature we all have. So kind of what, for example, depression teaches you is that it teaches you about the nature of sadness, because it's kind of like depression is like sadness under a magnifying glass, or personality disorder can teach you about sort of neurotic processes under a magnifying glass. And similarly, OCD teaches you about the nature of our minds and our thoughts. And one of the things you learn when you start to look at mindfulness, for example, is that your thoughts, you're not the thinker of your thoughts. Your thoughts, as I mentioned earlier, they pop into your head uncalled. And so there's this very interesting thing you do when you start to practice mindfulness, is where you start to disidentify with your thoughts. You start to realize that you are not your thoughts, and you have a choice to what extent you're willing to pay attention to your thoughts, identify with them, and have them influence your behavior, which I suppose is a big feature of then cognitive behavior therapy, which you can get onto.
Yes. The problem is that, there's no real evidence that things like mindfulness meditation are sort of helpful in anxiety disorders and OCD. Principles of mindfulness, being detached and not engaging and not making judgments about these intrusions, are very important, very good. But I'm just saying it's actually very difficult to do when you are very anxious or very depressed or whatever.
So the condition can be just too extreme.
Yeah. So we've got to be careful about that somehow just teaching people just not to engage with their thoughts and just let them go is theoretically very good, but it's bloody difficult when you've got anxiety.
So it makes sense in principle. But then, so what do you do in practice when someone has OCD? How do you begin to approach treating that?
Well, it really depends upon the nature of the problem. So, if you've got somebody with contamination fears and lots of avoidance, then, the cornerstone of a lot of that treatment is still good exposure in terms of helping people to face up to their fears and trying to transfer their perceived contaminant from, various contamination to the precious objects, or transferring them onto other people and so on. Because there are two main sides to exposure. One is learning to tolerate the emotion of anxiety and disgust and so on, and learning that you can bear it. And the second is actually to test out your expectations and proving to yourself that this is a fear problem, a worry problem, rather than a contamination problem. So the key thing in OCD is trying to develop a different understanding of what the problem is, and how the solutions of avoidance and checking and ruminating and trying to get control of things and wanting certainty, all these solutions are the problem, and they actually make things worse. And trying to essentially give up the solutions that they have and developing a different relationship with those intrusive thoughts and images.
So it's like going from one paradigm to another, where one paradigm might be, the world is a very dirty place and I'm going to get contaminated. That's the first paradigm. And the second paradigm is something like, I seem to be in this thought loop where I'm very preoccupied with contamination, and I'm stuck in these, that's causing me to engage in these behaviors to try and prevent contamination that isn't necessarily reflective of reality.
Yes, to see it as an emotional problem rather than a problem to do with you being able to influence and control the world in a rather magical way, or by ways of avoidance. And all these solutions are the problem that actually make things worse and strengthen it.
You must get quite a variation in clients being able to escape that sort of initial paradigm, and some must take longer than others. And are there any particular factors you've noticed which might influence that?
Well, in general, the more severe avoidance is going to take much longer and more difficult to engage. And so, the most severe cases are those people who are pretty much housebound and in bed all day and everything else. Individuals who have less insight and actually, or have what's more called overvalued ideas, who really identify strongly with those particular beliefs and as part of their self, are more difficult to engage because they really believe that what they're doing is the right thing to do, and everyone else is stupid. So, severity of avoidance, severity of the strength of your overvalued ideation are both very important. Very often other additional problems make it more difficult. So individuals who also suffer from autistic spectrum disorder have a little bit more, struggle more. People who perhaps are very underweight, have other eating, like disordered eating because of their OCD, are going to do worse. If you're more severely depressed, again, it's going to make life more difficult. So there's all sorts of things that make life more difficult, should we say, in treating those.
I guess it's a problem of abstraction, isn't it? It's abstraction and flexibility of thinking. Are you able to not just take your problem at face value, but create an abstraction from that and manipulate that so that you could see it in a different way, again, like we were talking about, not contamination itself, but a problem with contamination, say.
Yes, so I think we'd refer to it as, say, cognitive flexibility.
Cognitive flexibility.
To look at things in a different way. I suppose others might refer to it as being psychologically flexible, psychologically minded. So, of course, these sorts of problems are a lot easier to treat when you are more cognitively flexible. And the more intolerant you are of emotion and anxiety, again, it makes it more difficult. So individuals who are what's referred to as emotionally dysregulated, have more emotional unstable personality, then they struggle more because they're going to really find it difficult to tolerate the emotion and anxiety which might be generated when you're testing out your fears.
So you mentioned graded exposure. So that's like the classic behavioral treatment for anxiety, exposing someone to the thing that makes them anxious, the thing they're avoided in sort of an incremental way, which is very effective and really decrease the anxiety. And then maybe a step above that is something more like cognitive behavior therapy.
Yes.
Maybe you could talk me through, let's say someone is very afraid of contamination, and as a result, let's say they spend several hours a day washing their hands.
Mm-hmm.
Maybe you could take me through how cognitive behavior therapy could help them address that problem.
Yeah. So the first thing to do, as I said, is to have a really good understanding of what the problem is and what's maintaining it, what's keeping it going. And there will be certain other cognitive processes that maintain that particular problem. So we've already talked about some of the behavioral activities, particularly avoidance and use of various safety behaviors. Let's say a person is wearing gloves in certain situations, or as you say, wearing certain checking and washing their hands successfully. So all these things maintain and keep the problem going. But in addition, there'll be various cognitive processes, and particularly in terms of the intolerance of uncertainty. That is, the need to know something for certain, that nothing bad is going to happen if I don't wash my hands or something. So often it's the not knowing, which is far worse than actually knowing that something bad is going to happen. Yeah. And then individuals also often have an overinflated sense of responsibility in terms of the degree of influence they believe that they have in being able to prevent the harm. And the recognition that certain criteria may be used to finish washing. So, for example, I only finish washing when I feel comfortable or when it feels right in some way. Yeah? So it's important to be able to try and identify these particular criteria and processes and help people to recognize that perhaps the way they're thinking about these things are not very helpful and they actually make it worse. And there are different ways of thinking about it, and therefore different ways of solving this problem, because obviously the more that they stick with their criteria, for example, of only finishing washing or checking whatever when it feels right, when it feels comfortable, is actually going to maintain it and keep it going.
So really with CBT, you're kind of creating a very detailed map of all of the different processes which are perpetuating the issue. So the cognitive would be more like the thoughts, and then of course the emotions, and then the behaviors, and you're kind of examining the relationship between all three, how they perpetuate each other.
But in general, we don't tend to get involved in the content of that worry. So, for example, we don't go down the route of, well, what's the evidence that you're not going to get contaminated from this and things like this, because, OCD is a doubting disease, and there are no guarantees or anything in life. And so, of course, it's, even if you've got the evidence that it's not contaminated, it doesn't feel right. So we don't generally get involved in the content. Some types of CBT will get involved in some of the assumptions or beliefs about being contaminated, the idea perhaps that you might die and this is going to be dreadful because it's all to do with, a fear of dying, or, what will happen after you die in some way. So sometimes it's important to try and explore some of those issues, but we're not going to get involved in the actual content of the contamination or the great, the immediate threat.
Mm-hmm. That's very interesting from a psychological and I think also a philosophical perspective, to deal at the level of process rather than the level of content. I think about, for example, working with a socially anxious client, and they might say, well, I went to the party and this person definitely didn't like me and this person didn't like me and that person laughed at me, etc. And you might get them to think on a bit of a higher level, what was the process that actually socializing is a kind of bi-directional process where you're interacting with people. What did you bring to that interaction that might have influenced the course of events, but also how do you tend to interpret events? So you might, one person might interpret someone laughing at them as laughing with them, as it being a pro-social gesture, whereas another person might see them as immediately put themselves in what we call the one down position, like I'm not okay. So this way of thinking of process over content is something that I think a lot of people can benefit from, because a lot of people are very much, I guess to some extent, we're all the prisoners of our own process.
Yes, and sometimes it can be associated, you can explore some of the associations, some of the early experiences that might have led you to come to that particular conclusion, because very often, as we talked about before, some of those early experiences might still be influencing the present, and it still feels as if you're being rejected, or it still feels as if, from an early experience.
Yeah, so you're getting like these emotional echoes from the past.
Yeah, so it's important sometimes to help identify those, and sometimes the meaning that were associated with those early experiences, and sometimes it's important to try to help you emotionally process some of those early experiences.
Mm-hmm.
So that they can be brought up to date and no longer have a sense of nowness.
Yes, and especially if they're unconscious of it, if they have the emotional residue of the past experience without even realizing that this is from a past experience.
Yeah,
and thinking this is my body's reaction to the present.
Yes.
I saw a lecture that you gave on YouTube, and during that lecture, I do my research very carefully, and there was an OCD patient who was talking to his OCD, the empty chair work, which I found very compelling. Is that something that you've used a lot in clinical practice, or do you think it should be used?
I think I know the one you mean. The problem, so for many people with OCD and other emotional disorders, is that they view their problem as a bully. And you can have this very strong sort of internal critic, which in OCD, it's all about, the bully telling you what you must do and mustn't do in order to keep you safe. And sometimes it can be helpful to have a conversation with your bully to try to understand the motivation behind the bully. The idea that the bully is perhaps trying to keep you safe, or trying to do the best for you in some way. And sometimes it can therefore you can then go on to have a conversation with your bully that perhaps it's not acting always in your best interests, and that perhaps it's, not, we may be able to accommodate things better in by trying to learn how to develop more compassion and care towards your bully, so that you recognize that your bully is part of you, but that developing more self-compassion can be a more helpful way of approaching these things. So it's usually for more people with very long-term chronic problems who have a very self-critical, or can really recognize the bully as being like a sort of internal critic, and somebody who's there is trying to help you in some way, but there's all these sort of unintended consequences as well.
Mm-hmm. What was really striking about watching this patient, so he was talking to an empty chair that was embodying the OCD version of himself, or the part of him that was OCD. And then he started talking as if he were the OCD part of himself. He embodied it. And what I found striking was just how much it seemed to be so fear-driven. How when he was talking as the OCD version of himself, saying, "Listen, I'm just trying to help you. The reason why I'm bringing all these obsessions to the fore and why I want you to do these things is because I think you're not on the right track and you're going to waste years of your life." And the intense fear and anxiety that seemed to be driving it all, albeit with the face of a bully, the face of self-criticism, the face of aggression. And there was something very moving about that, really, that underlying all of this is just this deep fear, maybe be it an existential fear or a fear of not being good enough in some way. And it must be very cathartic to help clients become conscious of it, so they don't have to be driven by it all the time.
And I think that I've been involved in various OCD charities and for many years, and I think there's an abiding theme that they often feel very misunderstood and can't always access good treatment, good therapy. I can remember my very first conference, which we'd helped to organise for people with OCD and carers, probably about 1998 or something, at Red Lion Square. And there was a palpable anger from the audience in terms of, the people that we're just not getting the right help. We're not getting the so on. So it has improved over time, definitely improved, but there's still an almost sense of frustration about access to good treatment.
What do you think is most commonly misunderstood about OCD?
I think very often the message given to people with OCD is, just face up to your fears, just stop doing the compulsions, pull yourselves together sort of thing. And not really understanding that this is bloody difficult and really tough and requires a lot of courage. And I think sometimes, the nature of sort of self-help books and computers and so on is all very good and got good evidence for people with mild problems, but it's just not going to work with more moderate to severe problems. You really do have to have often your therapist and helpers alongside you to help you to do a lot of this stuff.
So it's a difficult process that needs a lot of unwinding, I imagine, because it takes years to develop, probably takes years to unwire.
And you've got to feel safe in those situations which you're trying to, develop that courage. And in general, the more severe and treatment refractory you have, the more intensive the therapy you need. And so that's why at our anxiety disorders residential unit, for example, people come for 3 or 4 months to have that sort of more intensive type of CBT on individual therapy 3 times a week, plus others helping you to do stuff in between the sessions, and occupational therapy that's really targeted at the particular problems as well. So that it needs to be full on all the time. But this is obviously for a very small group of people who are most severe and treatment refractory. But it's tricky, most people can make good progress, but maybe they don't always get rid of something completely. Yeah.
Yes. You must see some quite radical transformations at the residential units.
Yeah. Not everybody, but not everybody is ready for change at that particular time. And, I suppose, although we've been talking a lot about therapy, we mustn't forget as well that actually just as effective is the medication. The SSRIs, particularly in higher doses for longer periods of time. Again, it doesn't help everybody, only helps about 2/3 of people. But, often you do need, in combination with the therapy, that medication as well in the higher doses and for longer periods of time.
And is there any thought as to how SSRIs help with OCD? Is it merely the reduction of the background anxiety, or is there something more specific we know about that?
Probably. I mean, SSRIs, as you know, are marketed as antidepressants, but actually they're pretty weak as antidepressants. They're probably more effective as reducing anxiety. And of course, they're not specific to OCD or other disorders. They probably work by helping to reduce the overall severity of anxiety. And by doing that, it can help reduce your obsessions and compulsions. It takes the edge off.
Give you some breathing room to do the work that's necessary.
Very occasionally you come across people where they're cured by such things, and actually it's a bit of a double edge because they have to carry on taking it, and if they stop taking it, immediately relapse. Yeah, so it's actually very difficult to do any therapy with such individuals because you've got to have symptoms in order to be able to practice how to, to deal with it more appropriately.
Yeah, and I guess educating the people around them and the carers and the family so they really understand what the nature of this condition is, so they're in the best place to help them, must be very important as well, I imagine.
Yeah, and of course, families, particularly in the more severe condition, have got an important part to play because, like people, shall we say, with eating disorders, anorexia, the family may be quite involved in terms of accommodating a particular individual by helping in their avoidance and their compulsions, or they may become very cynical and sarcastic or aggressive, or they may just be highly avoidant when, obviously we want that relatives and loved ones to be more compromising and emotionally supportive and helping them to fight their OCD.
Maybe we could move on to talk a bit about body dysmorphic disorder.
Yeah.
How would you explain body dysmorphic disorder to a layperson?
Well, in a way, it's a sister to OCD in the sense that it's a preoccupation with perceived defects in one's appearance, and it's often associated with many repetitive type behaviours or compulsions of checking and the mirrors and comparing. And such individuals are often very, it's not just body dissatisfaction, it's usually on their mind for several hours a day, and they're constantly ruminating, comparing, and very self-focused, and trying to sort things and check and see if it's as bad as they think it is. And lots of avoidance behaviour in terms of camouflaging and trying to prevent themselves from being rejected or humiliated. And it's a very tough condition, again, to treat or to overcome. It's more difficult to overcome than OCD, and it's got higher suicide rates and attempts at suicide. So it's a difficult condition.
Is there a part of the body that's very typical that patients are very dissatisfied with?
It's usually around the face. It's typically around the skin, the facial skin, or the nose, or around the chin, or eyes, ears, and it's usually around the face, but it can be any part of the body.
Mm-hmm. And again, in taking the histories from these patients, is there something typical that stands out? Is there some theme of non-acceptance, of trauma?
Well, I would say the main emotion is again around anxiety and disgust or hatred of that particular bodily parts. And again, like in OCD, there is often a history of being teased or humiliated about some aspect of their appearance or other things in general just being different, but again, not necessarily. And it may be that they've seen or others who have been rejected or humiliated. So there is sometimes a clear history of being teased or rejected, about being different, but not necessarily.
Mm-hmm. And so is the treatment pathway largely similar to obsessive compulsive disorder?
Yes, in the sense that it does involve helping individuals to face up to their fears without their camouflage and things which they're helping them to resist the urges to check. And again, the focus is on the processes, particularly to do with trying to help people to understand the motivation behind comparing and ruminating, and trying to help them get them out of their head, and not, in other words, not to treat this as an appearance problem, but trying to treat this more as a body image or an emotional problem. Yeah, because at the moment, everything is devoted to trying to change or camouflage their appearance. And whilst you do that, then particularly when other people can't really see what the problem is, of course, it will drive you and everybody else around the bend.
Yeah, they think the problem is their physical form, whereas the problem is really the sense of inadequacy which they've inappropriately linked to their physical form.
Yes, and of course the solutions, therefore they believe, are often in cosmetic surgery or dermatological treatments and camouflaging in various ways, and all these things, of course, just make the problem worse. And it could just be spending hours searching for the perfect surgeon on the internet, or constantly monitoring and checking things in the mirror, and just it gets added to by the depression and other complicating things. But it's very tricky.
Have you had clients who have undergone a serious intervention, like a surgery, something along those lines, and they still feel that part of their body is ugly or disgusting? Say they reduce the size of their nose or something along those lines?
It's very difficult to do research in this area because it's very difficult to do these things prospectively. But in general, certainly by the time they come to our specialist clinics, they will have had experience of some form of cosmetic procedures. And interestingly, sometimes some of those cosmetic procedures they've been satisfied by, but then something difficult happens and they've been dissatisfied, or it hasn't done what it was meant to be doing. So there may be some procedures which are more risky than others. I mean, things like rhinoplasty and nose jobs and things seem to be definitely more risky. But say breast augmentation or something like that tends to be less risky, and so on. So it's a complicated area, and it's very difficult to do research in.
Mm-hmm. But anecdotally, have you met clients who have had these interventions and feel very dissatisfied?
Oh, absolutely. And I mean, sometimes they may be satisfied by a particular procedure, but they've still got BDD and they're still preoccupied, or it moves to a different area. So it's complicated.
So the worry might remain, but just move to a different part of their body.
Yeah.
Are there any lessons that you've learned? Because I feel like when I work with my clients, I learn a lot of lessons. One of the cool things about being a psychiatrist is you have the benefit of learning from so many people's life experiences.
Mm-hmm.
Are there any particular lessons you've learned from your patients that you really find helpful in your personal life?
I think I can always think of it as a blessing as not having a mental emotional disorder, and recognizing that one's own problems are just nothing compared to some people with problems that I've met. Now, it is difficult being human, and difficult to, I think, the suffering that you're going to have, whether it's from a mental disorder or whether it's going to be if you get leukemia or something. I think it's really tough being human, and I can often learn from the courage and the way that my patients face up to their fears and try to solve their problems in one's everyday life. Yeah.
And lastly, if you had a brand new psychiatry trainee in front of you, and you had to give some advice about approaching conditions like obsessive compulsive disorder, body dysmorphic disorder. What did you tell them?
I'd like them to really go out and live with that particular individual in their everyday life, in terms of what sorts of the things they have to struggle with, whether it's at home or in public transport or whatever, and really try to put yourself in the mind of that individual and what their lived experience is. Because there are so many subtleties of things that they're constantly having to monitor and check and do to try to prevent harm from happening. And just trying to give them a sort of almost like a running commentary on what it is that's going on. And really learn from your patients in that particular way.
To get a sense of just how debilitating it can be.
Yeah. Because often things that you notice, you observe, is only, half the picture.
Mm-hmm. You see the client in front of you, and I guess because so much of it is internal, you can be misled into thinking things are much better than they actually are. But when you're with the client, so to speak, taking history, and they're talking about cleaning for hours and hours or obsessively checking for hours and hours, and then you get a real sense of just how much of an impediment this is in their day-to-day life.
And I would also say to do your own experience of CBT, in the sense that, I can remember when I was younger in a workshop trying to challenge myself to going out and picking up some dog poo and rubbing it all over my hands and so on. So this is not the sort of thing, of course, we ask our patients to do, but it was a good way of, for example, feeling contaminated. And I can remember even after I washed my hands repeatedly that I still wanted to sort of feel, keep my hands out like a surgeon. And I still felt contaminated in my hands, even after objectively they felt clean. They were clean. Yeah. So it's these sorts of things that, having direct experience of doing exposures and things, which is a very powerful way of actually learning from your patients.
Yeah, I find if you look hard enough at your own experiences, you might not have a diagnosable mental health condition, but you can get those hints.
Oh, yes.
Those sparks of, I can see if this was 10 times worse, this would be, when I've checked something a little bit more than I've had to, and I can see how this could become a problem.
Another one I'd recommend, certainly for BDD, is to really get a nice mirror and put some depression music in the background, like Wagner or something, and really home in on those parts of you in the mirror that you don't like, and really ruminate about it, or compare yourself to something much bigger, and really want to try and change that bit of you. It's awful to keep it up for about half an hour. And this is what people with BDD are doing in front of the mirror, and it's just a ghastly experience.
Yeah, and you get the sense of the... I think there's a Marcus Aurelius quote: "The quality of your life is dictated by the quality of your thoughts."
Yeah.
Something like that. And you see, if you occupy that mental landscape, other things in your life can be going great, but the quality of your life can be awful. Yeah. Professor David Veale, thank you very much for joining me. You're welcome back anytime.
Thank you.
You are listening to a Maudsley Learning Podcast.